Hey there, ResusX folks. I am so sad I cannot be joining you in person, but hopefully this will be nearly as good. What I want to talk to you about today is lytic choices and the decision to provide fibrinolysis in sick pulmonary embolism patients. So the problem we have right now in the world of PE is that we only have 3 boxes that were being given to manage these patients. So we have stable, we have submassive, and then we have massive. That's not enough boxes. And the problem is that making decisions based on these very broad categorizations, they don't work. So what we actually need is we need 5 boxes. And if you have 5 boxes, now we can make some real decisions. We'll even add 6 because we'll talk about Peri-Code and coding patients. So you have your stable patients. They get admitted to the hospital. They get some anticoagulation. Maybe you even send them home these days. And we have some recent literature saying that if it's a subsegmental pulmonary embolism, they have no risk factors for further clot, that they might not even need anticoagulation. You might just watchfully wait those patients. So forget about those. I'm not really going to deal with those. I'm dealing with critically ill patients here today, right? So we'll get rid of those. All right. Then you have your not sick submassives, and I'll explain how to make that differentiation. Then you have your sick submassives, all right? So you have your not sick submassives and your sick submassives. Then, and this is where it gets a little annoying, and if you guys have better language, then tell me because I'd love to know. But you have your not super sick massives, and then you have your super sick massives, right? So not super sick massives and your super sick massives, and then you have the Peri-Code or coding patient. So we'll say 6 boxes for the purpose of this lecture, and we've already gotten rid of one of them, so we're back to the 5. Now, this is the MCRIT pulmonary embolism pathway. This is like beautiful mind level shit here, right? Like this is like the crazy chalkboard ramblings of an insane person. But unfortunately, this is why things like pulmonary embolism response teams exist, is because it's complex, right? It is a complex system. But I'm going to provide you the links to this, and you'll be able to check this out on your own in more detail. But we're going to go through some of the details now. So let's take a look at this. So when you zoom in here, we already are assuming you have a positive CT, or, if you're still in the Stone Age, is a high pretest probability, a high probability VQ scan. But come on, get the friggin' CT scan. And now you're going to risk stratify the patient based on the vital signs, the size of the clot on the CT, and maybe send some lab tests like BMP, troponin, and I would add lactate. And then, of course, because we're EM and critical care, we're going to do an echo. And based on that, we're going to risk stratify the patient. Now, if the heart looks normal sized and the patient's normotensive and their vitals are cool, then they're in that stable category I don't care about. Then you get the patient who's got some right heart enlargement, right? So submassive is defined by right heart enlargement. RV strain is the sine qua non for submassive PE. And they have normal blood pressure, right? So right heart strain, normal blood pressure equals submassive. But like I told you, that box, it's just too broad. It doesn't actually tell you what to do with these patients, except that they probably need to stay in the hospital. And they probably, unless they have a contraindication, should be put on anticoagulation. So that's what being submassive tells you, but it's not enough. So let's go down here a little bit. And now we have, do they have evidence of shock or respiratory failure? Now, this is where it gets interesting, right? So episodic hypotension. We know massive, we're going to tell you shortly, is defined by continuous hypotension. But what if they just are dropping their BP and then it spikes back up, dropping their BP, spikes back up? Their endogenous catechols come online and they spike back up. That's still a worrisome submassive patient. These are still patients who are potentially going to fall off the cliff. If their shock index is greater than 1, so their heart rate is greater than their systolic blood pressure. If they're having respiratory distress, or the patient is actually decreasing their saturation on anything more than a slight bit of FiO2, that's a problem, right? So if you have them on 6 liters, which is a very reasonable amount of oxygen, they're still satting poorly. That for me, that defines a sicker category. And then you can consider other things like lactate or super high troponin, etc. But that defines the category for me of sick submassive. 6 submassive, not just straight up submassive. 6 submassive is defined by having some evidence of the shock or respiratory failure. Now, you might say, well, can't we just use scores instead of like using this, kind of nebulous stuff? And like people like to use things like the sPESI score, right? No, that doesn't help you. That just tells you the patient's submassive. It might be useful for patient needs to stay in hospital. It doesn't tell you whether they need therapies like clot fibrinolysis. For that, if you wanted to use a score, I recommend the Bova score. And the Bova score is used at Shock Trauma Center. That's where I got experience with it. But it's basically the stuff you'd expect, right? So again, systolic blood pressure, elevated troponin, RV dysfunction, and then again, heart rate. Looking for things like shock index, but it's pretty much what we just spoke about. You could get a scoring because the individual items have relative differences. Now, the Bova score gets much better if you add in a heart rate greater than 140 and give additional points for that. So that's one modification of the Bova score. And if you add in lactate, and the two together, so lactate in there, heart rate greater than 140 in there, it could become a very accurate score. I'd like to see one more validation before I really say ready for prime time use. Now, so what do you do if you have a clot in a 6 submassive clot? What do you do there? So again, we'll go down to this beautiful Minds diagram, and we'll first assess for bleeding risk. All right, so that is step one. Now, if the patient's low, and I have the entire categorization of what makes them low, moderate, and high. You kind of get it. It's here on the diagram, right? So, high bleeding risk is things like previous ICH, et cetera. I'm not going to go through all of it. Moderate bleeding risk is, age gets in there. And then the minor bleeding factors, uncontrolled hypertension, et cetera, right? So based on that categorization, low, we're going to talk about some actual fibrinolysis. Now, you could send those patients to interventional radiology. My personal belief is with the doses I'm going to tell you about, that's not necessary anymore. Moderate, again, you could either do reduced dose fibrinolysis, or you could send them for things like catheter-directed lysis or clot catheter embolectomy. And then high risk, I really feel those patients deserve some form of intervention rather than systemic lysis. But the interesting category for me, and the one I really want to spend a little bit of time on, is this low bleeding risk patient with a 6 submassive. Categorization of their risk. And in those patients, I think you really have two choices. You could do the MOPIT dose, the half dose Alteplase, 50 milligrams over an hour. And it's going to have relatively low bleeding risk, especially in a young patient, but it's not no bleeding risk. For me, there's something better. And that's what I want to spend a little bit of time on now. And that is 25 milligrams of Alteplase over 6 hours. And so what happened is there's a guy named Akin in Turkey. He's a cardiologist who does a lot of work with reduced dose fibrinolysis. And he did a study that I helped to get published. And that study included 37 patients with not even 6 submassive, but these were 37 patients who had what I call not super sick massive, not super sick massive, meaning they were all on norepinephrine due to hypotension. 37 patients on norepi. And what he did in these patients is he did pre-echo, lactate, troponin, etc. All of them were elevated. Big RVs, elevated troponins, elevated lactates on the norepinephrine. And he gave these patients 25 milligrams of Alteplase over 6 hours through a peripheral IV. 25 milligrams over 6 hours. And then if at that 6 hour mark, these patients were still showing signs of instability, he was going to give another 25 milligrams over 6 hours. Guess what? All 37 patients off norepinephrine. All of them improved their echo findings. The RV strain got better. Their troponins all got better. Their lactates all got better. Were there bleeding risks? No, not at all within the fibrinolysis timing. Now, 2 days later, there was some gingival bleeding in a couple patients, and 3 days later, there was epistaxis in another patient. But that was well outside the window for the fibrinolytics. You could argue hours, but let's even give it 24 hours. No bleeds within 24 hours. All the bleeds were from the heparin. So 25 milligrams over 6 seems safe, seems efficacious, and is my choice in the patient with low bleeding risk and a 6 submassive. Okay, now remember he did these in massive. patients who weren't super sick. So you could extend that as well. We'll talk about that in a second. So I markedly prefer this over the Moffitt doses. Could you do this in a moderate bleeding risk? I think you can. This is a very low dose of fibrinolytics. It's not just 25. It's 25 over 6, which is not the same as 50 over 2, because it's not just the dose of the fibrinolytic, it's how long it goes in over. So 25 over 6 is a remarkably low dose. So this is something to consider. Read the paper, decide with your group in the hospital, your intensivists, your interventionists, etc. But I now make this my treatment of choice for 6 submassives with a low bleeding risk. All right. What about the clot in the sick massive patient? Well, let's first of all do the not so sick, right? We'll first do not sick massive. Okay. So let's zoom in the beautiful minds diagram here to, they got a massive PE and they have a low bleeding risk here. All right, so low bleeding risk, massive PE, and now you're going to, how sick they are is going to determine like how far up this scale you go. But you have the choices of the Moffitt dose, 50 over 1 to 2 hours. You could give them full dose. I don't think you should unless they're really Peri-Code. You could give weight-based Tenecteplase if they're Peri-Code. But if they're in this not sick, not so sick massive, you could also give them the 25 over 6, because remember, that's what the Aiken trial actually dealt with. If they're in the sick category, right, then you might want to go to the higher dose. Might want to go to that Moffitt dose of the 50 over 1 to 2 hours. But honestly, you could even try the 25 over 6 in those patients. But, if they're right at the edge of the cliff, you might want to get in something quicker. So the Moffitt dose makes a lot of sense. I never give full dose Alteplase unless a patient's Peri-Code, because even if I plan on giving the full dose, what I'll do is I'll give 50 over an hour, and then I'll go back to the bedside and say, hey, did the patient get much better? Great, stop. If they didn't, then I'll give the second 50 over the next hour. And I'm getting the same FDA-approved 100 milligrams over 2-hour dose, but I have a stop point where I check them and see, do they really need that second 50? So I think that's a great way to go. Now, what do you do if they're in the moderate bleeding category? Okay, so now, again, that 25 over 6 becomes more appealing because it has a lower bleeding risk. You could do the 50 over an hour. You could do full dose Alteplase or Tenecteplase, depending on how sick you think that patient is at the moment. And if they're high bleeding risk, then I don't think you give any systemic fibrinolysis. And in those patients, consider things like catheter embolectomy, catheter-directed lysis, open embolectomy, or you could put them on ECMO, let them chill, and then you can figure out what to do later if that's an option in your hospital. All right, now what about the Peri-Code or coding patient? So if they're Peri-Code, I think they deserve full dose Lytics. It makes a lot of sense to me to do Tenecteplase for that, because then the nurses don't have to worry that you're using a non-approved dose of Alteplase, which would be 50 milligrams pushed. They get scared sometimes, appropriately, because it's a high-risk medication and you're doing something off-label. So Tenecteplase, because they just used package instructions, makes a lot of sense to me. Now we're seeing half-dose Tenecteplase come on board for a lot of different things. Like now we have a STEMI trial with half-dose Tenecteplase, and we have a lot of stroke trials with the reduced dose Tenecteplase. I would like to see someone show me in this, Peri-Code massive PE patient, can I get away with half-dose push Tenecteplase? And I'd really, really be happy with that. Just like we're doing half-dose of Alteplase as a push. That would make me happy if someone did that study. But that's what I do, is I do right now full-dose Tenecteplase, definitely in a code, and for my Peri-Coding as well. Or you could do 50 milligram push of Alteplase in either of those scenarios. All right. So, like I said, I'm going to give you the link for the full pathway, and let's sum it all up. And this diagram is everything I just said. Now, the greater the patient's severity, right, the more I actually want to increase my fibrinolytic dose. And the worse the patient's bleeding risk, the more I want to decrease it. So that's the tensions I'm under. So if you have a patient who is Peri-Code or coding, give them full dose Tenecteplase or 50 milligram Alteplase push. If you have a patient who is a super sick massive, maybe you want to give them the full dose of Alteplase over 2 hours. Maybe you want to give them half dose, the Moffitt dose, right? You could even, like it kind of touching, depending on the bleeding risk, the 25 milligrams over 6 hours. Then you get your not super sick massive. And for those patients, I stay away from full dose of either of the fibrinolytic agents. For those patients, I would use Alteplase half dose, 50 milligrams over 1 hour. or 2 hours. Or Alteplase 25/6 is really my choice, my dose of choice now that we have a study out there saying it. Or you even, depending on their bleeding risk, we didn't really mention this because catheter-directed lysis has kind of subsumed it. You could give a much lower dose. You could give 24 milligrams over 24 hours or 8 milligrams over 8 hours. You have all those options. In the sick submassive patient, for me, it's going to be really that Alteplase 25 milligrams over 6. That's really what my practice is now. You could, I guess, give that mop at 50 over 1 to 2 hours. I think it's too much. You could give this very low dose peripheral 1 milligram an hour for like 8 to 24 hours. We don't have literature on that, unfortunately. Not sick submassive, give them nothing. Just let them chill. Even if they have large PE, we just had a trial showing it doesn't matter the size of the clot. If they have no signs of instability, do not give them fibrinolysis. And then obviously for the stable patient, we give them nothing. All right, if you have questions, you could shoot me an email or hit me up on Twitter. And it was such a pleasure to get to talk to you.